Thanks Dr. Lala, Dr. Pinney and Dr. Mancini for the opportunity to present this work. I guess I'm foremost a cardiologist that is trying to help people, so this opportunity arose. It was a bit of a no-brainer, as you'll see, to get into this field, and I just seized the opportunity. So just to give you an overview of what I'm going to present this morning, first a brief review of sarcoid so that we're all on the same page. It is a complex disease, and I think it's helpful to just give some of the background. Some of the current options for diagnosis of cardiac sarcoid and the problems that we face with the current modalities that we have and still have, and the emerging superiority of hybrid PET-MR for the diagnosis and management of cardiac sarcoid. So just to quickly rip through sarcoidosis in just a few minutes, it's a multi-system granulomatous disease of unknown etiology affecting young adults, commonly under the age of 40. It comes with this classic clinical and radiographic findings, often but not always, and with histologic evidence of non-caseating granulomas. So you can think of it somewhat like the reaction to tuberculosis, except it's not an infective form, it's an immune-based problem. And you have to exclude other causes of granulomatous inflammation, such as TB. 90% of cases of sarcoid involve the lungs or the mediastinum, but it can affect almost all organs of the body. This is a granuloma. This is really the core of the disease of sarcoid. It's actually in the liver, but you can see here this inflammatory infiltrate, this granuloma, intense inflammatory cell infiltrate, predominantly T cells and lymphocytes. So what's the epidemiology and how common is this? The overall prevalence is about 40 per 100,000 people. Incidence is greatest in the 20s to 30s. There's a 2-to-1 ratio of females over males, and also a preponderance in African Americans that's about 3 times that of Caucasians. Cardiac involvement is reported in about 5% of patients with systemic sarcoid, but the true cardiac involvement is actually likely much higher than that. So this is the clinically manifest involvement, but at autopsy, cardiac involvement is found in sort of a quarter to almost half of people. And in most, obviously, that's been subclinical, except for the people that actually just die from cardiac sarcoid as their first presentation of the disease. And imaging, as I'll show you, is contributing increasingly to the detection and management of cardiac sarcoidosis. Just to quickly give you a sense of the many ways it can present, cardiac sarcoid can be asymptomatic, and thankfully in most people with cardiac sarcoid it is asymptomatic, but it can present with just this broad spectrum of different presentations. It includes heart failure, palpitations, sudden death, EKG changes, syncope, pericardial changes, even cardiac ischemia and angina. So very heterogeneous, and it can be very difficult to diagnose for this reason. So how do we diagnose it? There are various diagnostic criteria, but the one that's come to the fore most recently is the Heart Rhythm Society consensus recommendations that came out in 2014. And they put forward 2 pathways to the diagnosis of cardiac sarcoid. The path A is the preferred but the rarely taken path, which is a histological tissue diagnosis from the heart of non-caseating granulomas. And just to talk about a tissue diagnosis for a second, it's spectacular when we get it. This is interatrial septum. You can see non-caseating granulomas, pericardium, the same thing. However, endomyocardial biopsy for sarcoid has a very low positive yield. It's around the order of 10 to 20%. There is a higher yield in patients with heart failure than conduction abnormalities, because heart failure implies more widespread involvement of the heart, so we're more likely to hit sarcoid tissue when we do an endomyocardial biopsy. There is morbidity and mortality associated with this, and as you know, in the heart failure context, most of our biopsies are done in heart transplant patients. The transplant patients have had open cardiac surgery and usually have quite extensive scarring of the pericardium. So the complication rate of biopsying a heart that hasn't been transplanted, is just a virgin heart, is higher because it's easier to cause substantial harm with pericardial effusion and tamponade if you're unlucky to go through the right ventricle. Negative endomyocardial biopsy does not exclude the diagnosis of cardiac sarcoid. We don't withhold treatment on the basis of a negative endomyocardial biopsy, although it obviously gives us pause for thought. And if possible, rather than endomyocardial biopsy, we prefer lymph node or lung biopsy if it's possible, because it's far safer and the diagnostic yield is far higher. And really at the moment in the expert consensus guidelines, there is little role for blind endomyocardial biopsy anymore. And if you find yourself wanting to do an endomyocardial biopsy, it's preferable to use electroanatomic mapping or image guidance to do so. So to the second pathway, and the far more common way we diagnose cardiac sarcoidosis, is to have tissue diagnosis from an extracardiac organ, typically the lungs, mediastinal nodes, and after ruling out other causes, finding one of these to be present. So this is the Heart Rhythm Society guidelines. It's a little bit flavoured by rhythm problems, but immunosuppressive cardiomyopathy or heart block, reduced EF, unexplained VT, but most commonly these imaging modalities, other modalities used to confirm the diagnosis of sarcoid, which is cardiac magnetic resonance imaging or PET study, FDG PET, and I'll come to those now. So to talk about imaging for cardiac sarcoidosis, gallium was previously used a lot. It's very specific, but it has very low sensitivity. So we are not using gallium at all at the moment in the management of our cardiac sarcoid patients. Really over the last few years, before the advent of hybrid PET MRI imaging, it had come down to using 18-fluorodeoxyglucose PET imaging versus contrast magnetic resonance imaging. And really the two modalities were complementary, but gave very different information, very different sensitivities and specificities. Contrast MRI was almost 100% sensitive for sarcoid, with a possible caveat, as we're actually understanding now, that very early cardiac sarcoid perhaps can have a normal MRI appearance. Contrasted with FDG, that was very sensitive but had a low specificity with high false positive rates. Very recently, these hybrid PET MRI machines became available, and we were very fortunate under Dr. Zahi Fayyad, who leads the Translational and Molecular Imaging Institute here, that he got one of the very first hybrid PET MRI scanners in the world. Still at this time, there's only about 70 hybrid PET MRI machines in the world in existence. There's actually quite a number of them in New York. There's about 5 that includes NYU, Stony Brook, MSK, but most of those are in use for cancer, which this has another great role for. But the advent of this fused PET MRI imaging really enabled us to capitalise on the advantages of these two modalities and to come together with an imaging diagnosis for sarcoid that really brought out the best and leveraged the best of these modalities to give us incrementally more informative data. So very soon after this machine was installed at Sinai a couple of years ago, we started to systematically refer patients for this imaging and to see what we could come up with. So we've now published a series of papers, 3 clinical papers and another 3 or 4 technical papers on this. And this was one of our first papers where we looked at patients with cardiac sarcoid and other diseases to see how this testing performed. So here you can see the contrast MRI. This is a patient with ischemic coronary artery disease and prior myocardial infarction. You can see here an area of contrast enhancement in the anteroseptum. You can see here on the PET there's absolutely nothing. You can see here these beautiful fused images, an area of scar with MRI, but absolutely no uptake on the FDG PET whatsoever, consistent with old scarring and no active inflammation in this patient. And here we got these, what I still find to be absolutely exquisite images of active cardiac sarcoidosis. You can see here in the lateral wall, late gadolinium enhancement, contrast positive, and here these localized and matching increased activity on the PET scan. And you can see here the fused images, beautiful co-localization of the PET with the contrast enhancement on MRI. I would say that there are limitations to PET right up front, and one of them is that the PET MRI is just showing us any inflammatory myopathy. So this is a patient, I won't go into all the clinical details, but it was a classic case of acute myocarditis. You can see here scar or enhancement on the MRI and uptake of the FDG PET. So this is not a specific test for cardiac sarcoid at all, and all of this needs to be taken in the correct clinical context. We then got on to a more systematic study, and this is the point that we decided this really does work and it looks very promising. We ramped up and really focused in on cardiac sarcoid. This paper is now published in JACC Imaging about 6 months ago. There's a whole bunch of missing images. Okay, for some reason there's back-to-back talks here. Let me just skip through. So we actually started referring these patients here. No, they're missing. Okay, we might have to get them to reload the slides, please. I'll just go back and talk to you about what we did here. Could you reload the slides, please? Is that possible? Good. So what we actually did was we started systematically referring these patients with cardiac sarcoid or suspected cardiac sarcoid for hybrid PET MRI imaging. And we actually then started referring patients just with any biopsy positive sarcoid for this modality. And what we found was that not only can you have active cardiac sarcoid, but there is this pattern of failed suppression. And this is really the Achilles heel of PET imaging, is failed suppression. So this is responsible for the high false positive rate of PET. And what we actually had always thought, and I had thought when we got into this, is that if you had uniform failed suppression, that actually was failed suppression of the entire heart, that was a fairly clear-cut case of failed suppression of glucose utilization by the heart. But we actually started finding these cases of failed suppression that were local, and they weren't involving the entire heart. So what we actually were confronted with in this study was these areas that had no contrast enhancement on the MRI, but highly positive regional PET signal. This is a patient that before the advent of these dual modalities, we may have well started immunosuppressing because the PET was positive. This led us to a whole series of detailed investigations looking in at the PET signal and how we can actually better understand the PET signal to manage cardiac sarcoidosis. And to summarise what we found, this PET signal has a characteristic kinetic pattern when it's associated with true cardiac sarcoid versus the failed suppression. And we did certainly confirm that you can have this regional failed suppression of the PET signal, which really changed our entire understanding of this imaging and of the disease. So with complicated actually bioengineering and bioinformatics, we actually managed to develop algorithms that look at the rate and the kinetics of this PET signal. If there's failed suppression of glucose utilization by the heart, the signal is immediately positive. If it's actually true inflammation and true sarcoid, the kinetics are much slower to become positive. So we're actually able to develop thresholds and cut points to enable us to use this signal to determine who has true sarcoid versus who has failed suppression. The slide's not reloaded, unfortunately. So just to close this part of the talk, we actually ended up for the paper and for our first work being very descriptive about what we did. And we ended up categorising patients as here this would be a patient that's MR positive and PET positive. I think in the right clinical context, this is a very clear-cut case of sarcoidosis. Patients here that are MR negative and PET positive, this is certainly the most challenging group to sort out, but kinetics analysis of the PET has been extremely informative to differentiate these. The third group was MR negative, PET negative. That's clearly, if both modalities are negative, I think you're not dealing with a significant case of cardiac sarcoid. Perhaps the occasional case is below the limits of clinical detection. And there are the cases where we see here where it's MR positive, PET negative. This is obviously either, it could be old sarcoid or another disease that's left residual scar. So just to close, we're also extensively evaluating this modality for other applications. It includes coronary artery imaging to look at active plaque information to see how we can actually discriminate a vulnerable plaque, a hot plaque that may need intervention versus a quiescent plaque that's very stable and unlikely to rupture. I would also add that one of the problems I think this talk has shown you is that the PET itself is great, but the FDG tracer, fluorodeoxyglucose, that we currently use is pretty lousy. And that's really one of the problems of all of this. And the investigation of alternative agents that can one day hopefully replace fluorodeoxyglucose is something we're intensely looking at. Zahi Fayad leads this project on McCoy, NIH funded, to look at alternate agents to F18FDG, including dotatate, which is extremely promising at this stage, and it looks like it may well be far more specific and sensitive for cardiac sarcoidosis. So to summarise, hybrid PET MRI I think adds incremental value beyond standalone PET or MRI, and I think we're obviously leveraging the PET to help with the MR interpretation and also the MR with the PET. There's low radiation, it's a single scan, and I believe this is a no-brainer that it's going to rapidly surpass standalone MRI or PET imaging for cardiac sarcoidosis in the near future as these scanners become available. So I'd just like to acknowledge all the people that I've had the privilege of working with, foremost Zaki Fayyad, who heads the Translational and Molecular Imaging Institute and secured all the funding for this scanner. Mark Dweck and a range of other people there that include bioinformaticians and engineers that help with the protocols. Maria Treveri, who's actually driven a lot of this work with me. Maria Padilla from the pulmonary sarcoid side, who's actually referred a lot of the patients, and Anu Lala, Mark Miller, who also helped with the clinical management. Thank you very much.